as we get into our atrial enlargements, let's talk about left atrial enlargement first. So a hypertrophy and enlargement of the left atrium. The telltale sign of left atrial enlargement is what we're going to call P mitral. And here we're looking at leads 1 and lead 2. So our limb leads, lead 1, lead 2. The P wave itself is going to be wide. So typically greater than 0.12 seconds, but it's going to be a little bit wide. But P mitral, you're going to see this notched P wave. And it looks like an M-shaped P wave. So it's a little, you see a little M, a little notch, a little M in your P wave in lead 1 or 2. Think mitral, think P mitral, and in P mitral we're thinking left atrial enlargement. So if you see P mitral, classic finding of left atrial enlargement. So if we see this, we see P mitral, that little notch in our P wave in lead 1 or lead 2, we have left atrial enlargement. So why would we see a notch? Why would we see this P mitral on left atrial enlargement? Well, that's because the right atrium depolarizes first. Right, our SA node is in the right atrium. That's where the electricity hits first. Right atrium is going to depolarize first and then go over to the left atrium. And since the left atrium is enlarged, hypertrophied, there's more muscle mass, more cells to depolarize. It's going to take a little bit longer to depolarize the left atrium. So that's why we see this kind of like right atrium, and then as we go down, the left atrium should have been done, but it takes just a little bit longer. A little bit longer, right? So we've got the right atrium depolarizing, and now the left atrium just takes so much longer to depolarize because there's more muscle mass. There are more cells to depolarize. There are more vectors going on, right? There's more stuff to depolarize in the left atrium here. We're not done. So we have P mitral, or think we might see P mitral in lead 1 or 2. Next we're going to confirm. So we're going to go to V1. And we're going to confirm in V1, and we're going to be looking for a biphasic P wave in which there is a positive portion and a negative portion to the P wave. So it's a little bit positive, a little bit negative. It's just like whoop. All right, it starts positive, goes negative, and then comes back to baseline. And in left atrial enlargement, that biphasic P wave, the second half of that P wave, the negative part of that P wave, is going to be a little bit bigger, usually a little bit wider than the first half. Because remember, the second half, if we're talking about that biphasic P wave, that second half is going to be your left atrium depolarizing. Because the right atrium depolarizes first. So even though it's the right half of the P wave, it represents the left atrium. That's confusing. That's a little weird, right? So just think the second half of that biphasic P wave in V1 represents the left atrium because the left atrium depolarizes second. So if that second half, that negative half, is wider than the first, that confirms our left atrial enlargement. So here's your a 12 lead for you. Let's go through our steps. First, our our rhythm looks like a sinus rhythm. It's probably a first degree AV block. Looks like that PR interval looks a little bit long. Axis. I am upright in 1. I am upright in AVF. We have a normal axis. We are good to roll there. So no axis issues. Do we have bundle branch block? Kind of looks like we do, maybe. I didn't measure that, so maybe just barely, maybe not. So it doesn't look like we do. I'm trying to measure with my eyes right now. So we're gonna say no. Do we have any ventricular hypertrophies? Kinda looks like we have left ventricular hypertrophy. Right, V1, this negativity, that is 5, 10, 15, 20, 25, 30, 35, 40, 40. Oh my gosh, that's like 45 right there. So we've got left ventricular hypertrophy. Don't have right ventricular hypertrophy. We don't have an R to S ratio in one or V1 or V2 greater than 1. We don't have more positivity than negativity. So no right ventricular hypertrophy. Go on to our atrial enlargement. So we're looking at lead 1, looking at lead 2, and I see, hey, look at that notch. Look at that M. I've got P mitral. Look at that. Look at there, right? So here's your P mitral. Here's your left atrial enlargement. We're going to go up to V1 and confirm this. I do have a biphasic P wave, and that second half, that negative half of the P wave, looks a little bit larger than the first half. So we can confirm left atrial enlargement. On this EKG, again, let's go through our steps. Rhythm is a sinus rhythm. I've got P waves. They all kind of correspond and look nice with our QRS complexes. Axis 1 is up. AVF is mostly negative, so I've got a left axis deviation. Well, we're going to split hairs a little bit there. So let's look at lead 2. Lead 2 is mostly upright, so I've got a physiologic left axis deviation. Not worried about that. We can move on. And then do we have a bundle branch block? And our QRS complex is wide. Look at that thing. That's wide. So we're going to look at V1, use our turn signal method. From the J point, we go down. Looks like a left bundle branch block. How do we confirm that? Lead 1 and V6. I'm looking for monomorphic upright mountains as QRS complexes, and I have that. So we have a left bundle branch block going on here. Do we have any ventricular hypertrophies? Well, maybe we do, but we can't diagnose that off the 12 lead. Because remember, with a left bundle branch block, we cannot call any LVH, any left ventricular hypertrophy. We can't call any RVH, any right ventricular hypertrophy, because this is just causing this screwy aberrant conduction patterns to begin with, so we can't really confirm LVH or RVH. Does this patient have LVH or RVH? Maybe, possibly. We just need to do some other tests, some other imaging tests. We can't tell off the 12 lead. So left bundle branch block, we're going to skip over our ventricular hypertrophies because we can't call it. We're going to go over to our atrial enlargements. Left atrial enlargement, which is what we're talking about, looking at lead 1 and lead 2. And here again in lead 2, don't see it so much in lead 1, but lead 2, I've got some notching. Looks like a little tiny M. Look at that, P mitral. Let's go to V1 and look at our P waves again, and we have biphasic P waves, a little tiny upward portion, positive portion, but a big old negative portion. So the negative, that second half of that P wave, is larger than the first half, and we can confirm that we have left atrial enlargement. On this third EKG, it's a little pixelated, but we can get through it. Let's start with rhythm. We've got this normal sinus rhythm, or at least a sinus rhythm. Looks like we've got a few running leads down at the bottom. Axis, lead 1 is upright, AVF is negative. We've got a left axis deviation. Let's split those into physiologic or pathologic. Lead 2 is negative, so I have a pathologic left axis deviation, so that starts to make me think of a left anterior hemiblock, right? Next step is to look at bundle branch blocks. And is this QRS complex wide? I'm going to argue it's just a little bit wide. Right? It's a little bit wide. So V1, let's just go along with that argument. V1, let's do our turn signal method from the J point right here. Going backwards, it goes down. Thinking left bundle branch block. What do I need to confirm that in lead 1 and V6? I need monomorphic upright complexes, and I have that in 1 in V6. So we can call this a left bundle branch block, and you might be thinking, well, this is a left bundle branch block with a left anterior hemiblock. Well, no, we're just going to call it a left bundle branch block, because if we are blocking off the entire left bundle branch, then we are in turn blocking off the anterior fascicle as well. So we're not going to call it a bifascicular block. We're not going to call it a left bundle branch block with a left anterior hemiblock, because that sounds silly when you think about it anatomically. So it's just a left bundle branch block. Because we have a left bundle branch block, we're going to skip over our ventricular hypertrophies, because in a left bundle branch block, we can't diagnose any ventricular hypertrophies, right or left, off of the 12 lead itself. Now we're going to go over to our atrial enlargements. So left atrial enlargement, I'm looking at lead 1, looking at lead 2. And I am ignoring this complex here, this complex here, this complex here, this complex here. If we go all the way down, remember this vertical line happens all at the same time. It's a big old PVC right there. And we do not want to be doing interpretations on aberrant beats and on PVCs or PACs or PJCs. So we're going to focus on the first two complexes here. Lead 1, lead 2, and I see a little notch right there in the P wave. Same thing in lead 2, little notch. Little M going on, little P mitral. Let's go to V1, look at V1. We do have a biphasic P wave, and that second portion is a lot bigger, a lot wider than that first positive portion. So we can confirm our left atrial enlargement. So causes of left atrial enlargement, very similar to left ventricular hypertrophy. There's just a pressure issue. There's a backload issue. So systemic hypertension, aortic and mitral valve issues, just general cardiomyopathies are going to cause left atrial enlargement. So anything that causes that left atrium to work harder is going to cause this enlargement, and even your left ventricle failing puts a little extra strain on your left atrium. So anything that's going to cause your left atrium to work harder, any systemic issues, because we're pumping that blood from the left side of the heart to the body. So systemic issues, systemic pressure, kind of back pressure, it's going to cause left atrial enlargement.